My name is Noopur Raje. I am a professor of medicine at Harvard Medical School and the director for the Center for Multiple Myeloma at the Massachusetts General Hospital Cancer Center in Boston. We are presenting the KarMMa-3 sort of longer follow-up data. I think most folks have seen this data set, which has already been published in the New England Journal of Medicine a few months or close to a year back now. And what the study has really done is taken patients who are triple class exposed. So everybody who has seen a proteasome inhibitor, an immunomodulatory drug, and daratumumab was allowed to go on to the trial. So they had to have between 2 to 4 prior lines of treatment. And really, if you put that into perspective, it is very similar to the phase 2 KarMMa trial. And what was done in this clinical trial was patients were randomized, and the randomization was done in this 2:1 way, so that twice the number of patients were randomized to the CAR T cell arm, and the other third of a patient population was randomized to just the standard of care. So all done, when we finished randomizing, we had close to 250 odd patients in the ide-cel treated arm, and the standard of care was about a third of these patients. And what we're presenting here is a longer follow-up. It's the 18-month follow-up. I think everybody is familiar with the fact that the PFS of this, the median PFS of this patient population was close to about 14 months compared to around 4 months in the standard of care, which really demonstrates that the risk of reduction of progression was as high as 51%. Now this continues to hold true all the way through about 18 months, where again the PFS in the experimental arm, which is the ide-cel arm, is about 41% at 18 months compared to 19% in the standard of care. I think it's really important to point out a couple of things about the KarMMa-3 trial. First of all of these patients were triple class exposed. And we know that in triple class exposed patients, these, generally the outcome is pretty poor, and on an average their PFS is anywhere between 3 to 5 months or so. And that is quite obvious based on what you see with the standard of care arm, even on the KarMMa-3 trial. The second thing to note out here was, of these patients who were triple class exposed, about 65% were triple class refractory. Now that is a really heavily pretreated patient population. And finally, 95% of patients on both arms were DARA exposed. Again, a difficult to treat patient population, and if we didn't have any of these novel treatments, on an average their PFS, as I've already said, is between 3 and 5 months. So really the KarMMa-3 trial has shown us that we can go to a larger patient population, and to me, I think the biggest highlight of all the KarMMa studies is we've been able to over and over again reproduce the data. There's no surprises. When it comes to toxicity, we've been, pleasantly surprised. Ide-cel is extremely well tolerated. We do see some CRS, which is really easy to manage. Most people would agree. Neurotoxicity is very low, if at all. So in general, easier to manage patients. I think the other really important thing to think about, because people then say, okay, the PFS is great, what about the overall survival? And I think when you think about overall survival, that was not the intent of the protocol. And number two, we absolutely requested our sponsors to include a crossover. We said we are not going to, at least in the United States, we would not want to participate in a trial if once they progress, you are not offering them ide-cel. So this allowed a crossover, and if you look at the real data, more than 40% of patients, more than 50% of patients got ide-cel, but at the time of the median PFS, up to 40% of the control arm had already gotten ide-cel. after 14 months, half of them had progressed, and therefore they ended up getting ide-cel. So there's no difference in overall survival, and that's largely because of the design of the trial, the crossover. A lot of the patients on the control arm ended up getting ide-cel, which to me is very reassuring actually. And then if you take a step back and look at this data set and say, hey, what if we didn't have a crossover? And if you adjust for that and adjust for the crossover and then look at an overall survival, obviously the overall survival would favor the CAR T-cell arm. What the KarMMa-3 trial, the way I look at this trial is, these were patients who were supposed to have received between 2 and 4 lines of treatment. If you look at what our FDA approval for CAR T cells right now is, they have to have received more than 4 lines of treatment. Otherwise, you're not going to get CAR T cells. I think the definition of lines of treatment is becoming a little more artificial now, and that's largely because we are combining drugs, right? We are combining 3 and 4 drugs at the outset. You're going to see at this year's meeting here at ASH, 4 drugs are going to be the standard of care for patients with multiple myeloma. There are 2 trials, one in the plenary session, one in the late breaking session, which is all going to be talking about 4 drug combinations. Now, if you're already exposed to 4 drugs after your first line of treatment, how can you get to the 4th line of treatment? And I do think the KarMMa-3 trial actually touches on this. And if you look at the patients who went on to the ide-cel arm, there's about 11% of patients who never got ide-cel, and that is they had to meet the criteria, they had to be triple exposed. As I've already mentioned, 65% of them were triple class refractory, difficult patient population, and about 11%, while the ide-cel was being manufactured for them, could not get the drug product itself. So again, highlighting the need for us to move away from lines of treatment, try and bring these treatments earlier so our patients can benefit from it, and this is so well exemplified by the KarMMa-3 trials. So for that reason, I think this is a great trial. I'm hoping that ide-cel gets a label wherein we can use this drug earlier on. It's really, if you look at the KarMMa-3 trial, though I've already said this, it is not an earlier line of treatment, but it is going to allow us to get more patients on so that they can benefit from these transformative treatments going forward. Clearly, the unmet need, looking at refractory disease, we know what the outcome of these patients is. We also know that these are the patients who are rapidly progressing. We do not have the time to catch them to give these drug products, and that's why moving all of these trials earlier on and providing access is absolutely critical. This is a long-term discussion that we've had with our investigators, our regulators, our pharma colleagues, of moving away from these lines of treatment to drug exposure, because in essence, when you're treating a patient in the clinic, you're looking at exposure and you're going to see whether or not a patient can get that drug product or not. So I think for those reasons, this is really important. And the earlier we can move these, there's a lot of clinical trials which are happening even in an earlier phase, not being presented in this year's meeting, but hopefully in the future meetings. And our hope is that we're going to start seeing a plateauing of the curves of all of these CAR T cell products.